Hello, and a very warm welcome to this live forum. And it's my pleasure today to be, as it were, hosting this. And here we can see the faculty. So it's a particular pleasure to be welcoming my friend and colleague, Riki Alton. She's professor and head of Department of Internal Medicine at the Schlosspark Clinic in the University Medicine Berlin in Germany. And Riki is an expert in many things. She has a huge experience in clinical trials, and she has literally been an inspiration to a generation of rheumatologists and continues to be. And so it's wonderful to have her join us today. And my name's Peter Taylor, Professor of Musculoskeletal Sciences at the University of Oxford. Here are our disclosures. And just a few quick housekeeping notes. So the attendees will be on mute for the duration of the meeting, but we're very pleased to take any questions which you can address to us by submitting them through the Q&A function, which you'll find at the bottom of the screen. If you have any questions or you're experiencing any technical difficulties, please use the chat box and one of the clever people in the backup room will be able to help you out. But usually the technology is very straightforward. So what are we going to talk about today? Well, the title of this forum is Rationale for Treatment Selections in Inflammatory Arthritis, and you'll all be aware that the whole field has become increasingly complex as choice has broadened. So I'm going to start off by talking about how we interpret clinical study designs. There's been a huge evolution, as you'll see. And then we're going to hear from Professor Alton about treat to target. And this has been a really key development over the last few years, but it continues to evolve. And then we're going to hear further about how real-world experience meets the clinical trial expectation. And this is such an important topic as well. And we have abundant data to discuss, some of which we'll share with you today. And then there'll be some time at the end for general discussion, and we'll do our best to address any questions you have. So please do feel free to submit them as we progress. So without any further ado, I'm going to make a start and talk about interpreting clinical study designs and trials for recent targeted therapies. Now, here are some of the issues, and I'm just going to minimize the video screen so I can see that. There we are. So here are some of the issues because there's been a huge evolution in clinical trials over the last generation. Both Riki and I have witnessed this and been a key part of it. So in the pre-biologic era, and we're going back over 20 years now, the focus was very much on limiting toxicity and demonstrating some degree of symptomatic benefit, which was often really rather modest. There were limited outcomes that were measured, relatively small numbers recruited into trials. For example, it's hard to believe now that methotrexate was approved for use in rheumatoid arthritis as recently as 1986, and it was based on just 2 randomized controlled trials with 126 patients, and the exposure period was less than 6 months or up to 6 months. So quite extraordinary, really, and a very different world to today. There were no head-to-head trials in those days. They tended to be placebo-controlled trials, and there wasn't any rescue therapy. And many of the trials just involved a single center or a handful of centers. And then everything changed, and I was privileged to be there in the early days of the biologic era, and the focus became on disease modification, showing that we could limit structural damage. There was rigorous testing with radiographic outcomes as well as clinical outcomes, and patient-reported outcomes were introduced. The numbers of patients recruited into trials became larger, the period of drug exposure became longer, between 6 to 24 months, and a few head-to-head trials begun to creep in. And the background therapy or early rescue therapy for the placebo arm became standard. And as you'll see, multiple centers tended to be involved right across the globe. And then more recently still, we've moved into the era of small molecules. And there we have systematic testing in multiple patient groups, an increasing importance of patient-reported outcomes, and more measures being assessed. But that brings some problems from a statistical analysis point of view, and we'll discuss those. So multiple secondary or exploratory endpoints may crop up, and we've seen many more head-to-head trials, and I think we'll see more as we continue. So this is a rapidly evolving field. Now, if you look at the particular populations that are relevant to contemporary management, they tend to be divided up as follows. Very often there'll be phase 3 trials in treatment-naive patients, in methotrexate inadequate responders, in other conventional synthetic DMARD inadequate responders, biologic inadequate responders, or head-to-head trials where two active comparators are compared. And increasingly, we're seeing those now emerging. So let's have a look at the issues that we're going to consider. First of all, we'll talk about head-to-head studies and look at the difference between superiority and non-inferiority trials, and also take into account the issue of equivalence trials. We'll look at imputation for missing data and how that's dealt with. We'll look at the role and impact of rescue therapy. We'll look at the pros and cons of long-term extension studies, and we'll also take a brief summary look at how safety data is reported. So let's start off by looking at head-to-head studies and consider the difference between a superiority study and a study designed to establish non-inferiority. And we'll also look at considerations around equivalence trials. So what do we mean by a superiority trial? Well, the idea here is to determine whether there's a clinically relevant difference between two treatments. And this may mean the test treatment versus placebo, or it could even be two active treatments, for example, a small molecule versus adalimumab. And of course, if you're comparing two active treatments, and if you want to show superiority, you may need a very large number of patients in order to have statistical significance. And we'll talk more about that as we progress. Equivalence trials are designed to determine whether a treatment is neither worse nor better, hence the name equivalence. And this has been particularly important when it comes to biosimilars and comparing the efficacy of a biosimilar to the originator drug. And then a non-inferiority trial determines whether a treatment is not inferior to another treatment. And we'll look at examples of all of these. So in rheumatoid arthritis trials, nowadays, many new treatments are compared with the current standard of care, and very often that's considered to be an anti-TNF. Adalimumab has often been chosen because it has been the most widely prescribed anti-TNF, usually together with concomitant methotrexate. And again, we'll look at examples to illustrate this. So let's kick off with non-inferiority trials. So these are designed to show that the investigated drug is not inferior to or in any way less effective than the active control according to a pre-specified margin. So it's very important to choose what that margin is. And in fact, you'll notice in this example that you have a pre-specified inferiority margin of, let's say, 13%, minus 13%. Now, why choose 13% less efficacious than no difference? Well, the reason for this is that it's looking at the detectable difference based on the variation in measurement of, say, an ACR20 measure, the difference between the placebo and an active drug that might be expected, and the variability between different investigator measures. And that helps determine this minus 13%. So in this particular case, if you had a drug where the confidence intervals straddled minus 13% and went over that and over 0, then you wouldn't show non-inferiority. But if, on the other hand, you showed an outcome where the lower confidence interval was above the lower boundary but less than 0%, that would establish non-inferiority. And if again you had a situation where the new drug actually was above, in the lower confidence interval, was above 0, that could establish superiority. So let's look at an example now of a non-inferiority study. Now you may recognize this. This is the oral strategy study. So it's a fairly recent study which looked at the comparison of tofacitinib with or without methotrexate. The tofacitinib dose chosen was 5 milligrams twice daily, and it was in comparison head-to-head with adalimumab plus placebo. And what we're looking at here is the results. And you can see that, in fact, the combination of tofacitinib plus methotrexate met non-inferiority criteria versus adalimumab plus methotrexate. So, in fact, on average, there was a 2% outcome which favored tofacitinib, but the lower confidence interval was minus 6.4% and the upper was 10.9%. So that lower confidence interval is above the lower boundary of non-inferiority of minus 13%. And that means the combination is non-inferior. But if you look at tofacitinib as a monotherapy versus adalimumab plus methotrexate, the lower confidence interval crosses that lower boundary of non-inferiority. And similarly, if you look at the comparison of tofacitinib monotherapy versus tofacitinib in combination with methotrexate, again, it crosses that lower boundary. So we cannot say that non-inferiority has been met in those two cases. So this is a very illustrative study. And you'll note that it was non-inferiority for ACR 50. That was what was chosen in this particular study. Let's look at another contemporary study. This is the Finch 1 study in which filgotinib was investigated at 2 doses, 100 milligrams daily or 200 milligrams once daily, in comparison with either placebo as a placebo control or with an active comparator in the form of adalimumab plus methotrexate. And you'll note that all treatment arms are in combination with methotrexate. The primary endpoint was chosen to be ACR 20 at week 12, and there were a variety of other efficacy outcomes that were chosen. So this is a parallel arm, placebo and active comparator control study. And let's have a look at some of the issues. Well, this looks rather complicated, but I hope I'll make it very simple for you. So I've deliberately chosen to tabulate a number of efficacy outcomes either at week 12 or at week 24. And let's look at them one by one. So first of all, I'll highlight ACR 20, which is the primary outcome. And you can see that the primary outcome was met because ACR 20 for filgotinib 200 plus methotrexate was statistically significantly different from placebo. Now, if we look at another measure here, this is DAS28-CRP of 3.2 or less, so in other words, low disease activity or less. Here, non-inferiority to adalimumab was established based on this outcome. But if we look at another outcome again, and this is for DAS28-CRP at remission level, it actually demonstrates a statistically significant difference which meets superiority in as much as the lower boundary of the confidence interval was above 0, but the comparison was not adjusted for multiplicity. So in fact, we can't legitimately claim superiority overall, even though it is statistically significantly superior at that particular outcome measure. So it all gets a little bit complicated. Now, if we compare other outcomes here, here on the left-hand side, you can see plotted as a continuous measure the categorical outcome of ACR 20. And at week 12, you can see that there's this distinction between filgotinib at the higher dose and placebo. If we look at some different outcomes, DAS28-CRP of 3.2 in the middle, or DAS28-CRP of 2.6 on the right-hand side, you can see at a glance that there's a difference between the higher dose of filgotinib and adalimumab in the green, and obviously from placebo in the blue. And in some instances, this meets statistical significance. So you get the idea that depending on the outcome measure you use, you might actually achieve a statistically significant difference from the comparator or not. But the claims that you're allowed to make will depend on whether or not there's been multiplicity correction. So why do we need to adjust for multiplicity? Well, the issue is that we all know that rheumatoid arthritis relapses and remits. That means its disease activity is up and down. We know that there are potential variations between observers in measuring disease activity or outcomes. And we talk about what's called a type 1 error rate. And when we're testing a number of hypotheses simultaneously, we need to take into account that we allow a certain degree of type 1 error. So if we allow an alpha level of 0.05, that means we allow this error to occur for up to 5% of the time and say, well, actually, if P is less than or equal to 0.05, then we consider that to be significant. But we accept there's a small possibility of a type 1 error. And you can see in the chart on the right that if you consider all the outcomes as primary outcomes, really you need to adjust for multiplicity. Similarly, if you look at repeat measures of the same outcome, you need to adjust. But if you're looking at multiple secondary outcomes, it's not necessarily so important, but we need to take into account all these issues when we interpret the clinical trial data. So let's put all of this into context. So let's now consider the issue of superiority trials. And here, if you want to show superiority, the lower confidence interval of the data from the test drug has to be above 0, and that would show superiority. Whereas you can see in the bottom part of this cartoon that you would not show superiority if the lower confidence interval is less than 0. So let's take a look at an example. Let's look at the Select Compare study, which was a study with the JAK inhibitor upadacitinib. And again, we're looking here at a placebo and active comparator controlled study. And the primary endpoint was ACR20 at week 12. There was also a DAS28 CRP in the European area as a primary endpoint, looking at the proportions of patients meeting remission criteria by that measure. But can we actually make claims for non-inferiority or superiority based on ACR20? Well, let's look at this in more detail. If you have an analysis like this, you have to have a pre-agreed analysis set. And the full analysis set looks at all the randomized patients who've received at least one dose of study drug. And if you look at how we handle anybody who drops out because of non-response, or if they drop out of the study, we have what's called non-responder imputation for the categorical endpoints, such as the ACR measures. But for the continuous endpoints, like the DAS28 CRP, we use something else called multiple imputation or mixed effect models. And for radiographic data, we look at linear extrapolation or as observed data. So all of this becomes rather complex, and we're going to look at examples of each. So the issue is you need a predetermined analysis plan, and then you have to stick to that when you have your data. And here's an example of the analysis plan. Now, the regulators in America and in Europe have different ideas. So on the left, you can see the FDA American idea of the importance in hierarchy. And on the right, we have the European idea. And you see that we rank the different endpoints after which we can only look at after you've achieved non-inferiority for the primary endpoint. So the primary endpoint of ACR20, let's take as an example, you then have to go through all these rankings, 1, 2, 3, 4, and 5, and have statistically significant difference for all of those in order to get down for the claim for superiority, which is right down at rank 11 for ACR50 for upadacitinib versus adalimumab. Similarly, in the case of the European Union, there's a different order of hierarchy because a different priority is placed in one area geographically than another. So here you see some of the key and important outcomes. So now let's go back to the study and look at the issues. So multiplicity control was applied to the primary outcome and several ranked secondary endpoints. So they had to be pre-specified and adjusted for multiplicity on the basis of ACR 50 and the patient's own assessment of pain and function measured by HAQ-DI at week 12. And now let's look at the data. Well, in fact, if you've established non-inferiority, which was the case in this study, you can legitimately go on to look at superiority, providing it's in the pre-analysis plan, as I've just shown you. And then the actual p-values for superiority have to be presented to allow an objective and independent assessment of the strength of the evidence. In other words, we're looking at probabilities that this really represents reality. And here's an example. So ACR 20 were met for the primary endpoint in the USA area. But here, if we look for ACR 50, which was down at number 11 in the ranking, you can see that superiority is met for this outcome with multiplicity adjustment. So the lower bounds of the confidence interval easily exceed 0. I hope that makes sense. On the histogram on the right-hand side, you can see the actual data, 45% achieving this outcome with upadacitinib, whereas 29% achieved it with adalimumab, and both patients had background methotrexate. Let's turn our attention now to an equivalence trial. For example, you see in biosimilars, this was from a very nice paper from our faculty member, Professor Alton. And here, a beautiful illustration of the difference between equivalence, where the confidence intervals boundaries have to lie between the equivalence margins that have been preset. If your lower confidence interval exceeds 0, but exceeds the upper equivalence margin, then that doesn't count as equivalence. That would be a bio-beta, and the drug wouldn't pass as a biosimilar. And in the same way, if you're at the lower level and your lower confidence interval is below the lower equivalence margin, then you would fail to show similarity or equivalence. So that's very important in biosimilar trials. How do we handle missing data? Well, there are lots of ways of doing this. The most conservative is to use non-responder imputation. And this means simply that if any patient drops out, they're considered a non-responder. So it's going to draw down the overall level of response for the population as a whole. Another way of doing it is to use what we call intention to treat with multiple response imputation, or to use a last observation carry forward. So in other words, if the person who drops out has had some response when they drop out, you simply carry that forward and assume that that response would have been maintained if they remain in the trial. Or you could just look at the patients who finish the trial. The difficulty for that is that it biases towards patients who are responding well. So we have a gradation of either very conservative measures or less conservative measures. And let's look at the influence of this in one of the upadacitinib trials. This is the SELECT monotherapy trial with 2 different doses of upadacitinib tested. But as you all know, it's only the 15 milligrams once daily that's the approved dose. But you can see in the solid lines that are plotted continuously that if we look at as observed data for the patients who finish and complete 48 weeks of exposure, overall the data are higher than if we look at non-responder imputation in the histograms, because there, anybody who's dropped out for whatever reason, maybe they're going away and moving house, but that would still mean that they're counted as a non-responder, even if they were actually responding. And the consequence is it brings down the average level of response of the cohort as a whole. So it's important to look out for these things when you see clinical trial data, because the way in which we interpret it depends on understanding these issues. And sometimes it's very useful to look at all the different ways of measuring the outcomes. Now, another method that we can use is what's called last observation carried forward. And that's often used in the case of continuous variables, such as the DAS28-CRP or as the HAQ-DI. And this may underestimate, for example, the radiographic progression at any time, because we know that if you didn't treat patients at all, there tends to be a linear progression of worsening. So another way of dealing with this is to do what we call linear extrapolation, where you take the progression of structural damage over 2 time points, draw a line between them, and carry on with that line as if the natural progression of radiographic damage would just be linear. It would be a straight line over time. So that's what we call linear extrapolation. Now, it really matters when you interpret trial data, and let me illustrate that with an example. This is an example from the baricitinib clinical trials. RA Build was in conventional synthetic DMARD inadequate responders, and RA Beyond was in biologic inadequate responders. And this is pooled data looking at radiographs from both populations. And on the left, if you look at the last observation carried forward data, you'll see there's no statistical difference in radiographic inhibition between the baricitinib 2 milligram dose and placebo at week 48. But if, on the other hand, we apply a linear extrapolation, which we believe is more closely aligned to what would happen in real life natural history of the disease, then all of a sudden, there's a statistically significant difference between placebo and the 2 milligrams of baricitinib. So we have to interpret these data accordingly and remember that we're looking at a probability based on the measure that's actually used and the statistical analysis that's undertaken. So very important issues to bear in mind. Let's now look at the impact of rescue therapy in contemporary trials. In the days gone by, a generation ago, if a patient simply didn't respond to drug, the viewpoint was, well, it's too bad. We don't really have any treatments that really work, so we'll just leave it. But nowadays, it would be considered unethical to leave a patient on a treatment that's simply not giving any benefit, or even to leave them on placebo for any length of time. So you simply won't see a patient with rheumatoid arthritis treated with placebo for a year, for example. And so if a patient fails to achieve a predetermined level of improvement, then actually they could have open label administration of the same active agent that's being tested, or a different active agent, or even an additional active agent. So there are lots of different choices. Now, the difficulty with all of this is it makes interpretation of the findings even harder, because if you start rescuing patients after a certain period of time, it reduces the overall observed treatment effect. And if you use an intention to treat analysis, which is quite conservative, it means it will increase the sample size that you have to use. And of course, if it turns out that there's any risk of the new test therapy, potentially you could be placing patients at more risk. Now, it may be that you're not placing patients at more risk, but it is a possibility. So this becomes a very complicated ethical issue when designing contemporary trials. So let's look at another example and go back to select compare. So here, in this particular study, if patients didn't respond to any one of the initial treatment assignments, they were switched to an entirely different treatment. So patients not responding to upadacitinib were switched to adalimumab. Patients not responding to placebo were switched to upadacitinib, and patients not responding to adalimumab were also switched to upadacitinib. And this meant it was almost a treat to target study, because the treatment was being changed every few weeks if an inadequate response had been observed to the original treatment assignment. So here we can see the rescue could be undertaken between week 14 and week 26, so at lots of different time points. And then if we use a very conservative non-responder imputation, we still in fact see a separation between upadacitinib and placebo, and also between upadacitinib and adalimumab. But nonetheless, the average response is brought down a little bit because of this rescue issue, where people who are rescued are counted as non-responders. Let's look at another example. So in the RA Beam study, so this was a study of baricitinib compared to both placebo and adalimumab in patients with an inadequate response to methotrexate. And I've put here a pictogram so you can get some idea of the effect of this rescue therapy. So if patients were not adequately improving by about 20% from baseline, they could be rescued at week 14 and 16 to open label baricitinib, and that's fine, but it means that those patients with a non-responder imputation would be counted as non-responders going forward. So in fact, a proportion of patients were rescued early on, and some other patients discontinued treatment. It may have been even placebo they discontinued, but for one reason or another, they didn't want to stay in the study. And the consequence, as you can see in the pictogram, is that effectively takes out a small proportion of patients who were included in the study. And therefore, it will bring down the apparent influence benefit of the drug. And so we need to bear that in mind when interpreting the outcomes. And yet that still was the first study to show superiority over adalimumab for a small molecule. One of the other things you'll see in contemporary trials is long-term extension studies, and they're often published after the initial primary study. And the idea here is to keep on treating patients who want to stay in the study just to confirm that there's maintained efficacy over time and to ensure there's no new potential safety signals. And what usually happens is in the long-term extension that patients are unblinded, so they are often in an open label administration. They know what drugs they're getting. And again, that may bias their response to treatment, but nonetheless, it can give very useful information. But as always, there are challenges. Some patients will drop out and they'll be missing data. Unfortunately, as we all get older, some of us will depart this life. And even if it's not related to drugs, there will be some deaths because that happens as in an aging population. There may be selection bias because patients with inadequate response or intolerance to the study drug may be those who are most likely to drop out. It may be that this will render the powering inadequate to make statistical comparisons. And usually there's no control group because it wouldn't be considered ethical to leave a patient on an inactive control for a prolonged period of time. So long-term extension studies are undoubtedly useful, but they do have their challenges when it comes to interpreting them. And finally, let's look at the issue of safety. Well, of course, it's very important to look at safety in clinical trials, but don't forget that even in huge phase 3 clinical trial programs, such as the ones we saw for baricitinib or upadacitinib, that the overall numbers are still relatively small. We're looking at a few thousand patients, and that might not be sufficient to pick up a rare association between the test drug and a rare adverse event. So control trials are very valuable, but they may not properly define any safety issues. Long-term extensions may give us more information because it's a longer exposure to the drug. And then there are post-marketing surveillance studies, such as oral surveillance, which give other data as well, but also need some cautions around interpretation. And then there are registry studies and real-world data. And of course, we're going to hear from Riki about some real-world data shortly. So just in brief, to bring you up to speed with some of the things to look out for, we tend to work out the patient years of exposure. So if, for example, you have 50 patients who are treated for 2 years, that is counted as 100 patient years of exposure. And if over that time period, 3 patients had adverse events, that would mean 3 patients in 100 patient years, and that would mean an exposure rate of 0.03 per 100 patient years. So it's very simple mathematics to look at it like that. But that's what the incident rate per 100 patient years of exposure means. Another measure that might be used, for example, if we look at malignancy rates, is to look at the observed number of cases and then to divide that by the expected number of cases. So, for example, if we're looking at melanoma skin cancer, we might look at the observed number of cancers in a JAK inhibitor trial and then divide that by the expected number in a rheumatoid population based on a huge national database. Or it might be compared to an otherwise healthy population. And in fact, in the case of JAK inhibitors, it turns out that if anything, that proper control of inflammation reduces the risk of many different types of cancer. So again, this is a useful way of looking at data. If we look at relative risk, this is looking at the risk of an event in an exposed population comparing to the risk of an event in an unexposed population. So if you get a relative risk of 1, it means there's no difference. If, on the other hand, there's an increased risk in the exposed population, even just a small increase in risk, it will give you a relative risk of just above 1. And that means the risk is more likely to occur in the exposed group. But then again, we as physicians need to compare that relative risk of an adverse event with the likelihood of benefit from treatment. And somehow we need to explain that to the patients so they can draw their own conclusion. So to conclude this part of our live forum, what we've seen is there's been a huge and profound evolution in the design of clinical trials over recent years. And we have to take into account multiple factors when we as clinicians interpret these clinical trial designs. And it includes the patient population that's included, the imputation rules that are set at baseline, the selection of endpoints, and whether or not there's a predefined statistical analysis plan, and also whether that takes into account the comparisons for multiplicity corrections. And by carefully understanding what the trial tells us about benefit and risk, this is based on the limits possible within clinical trial data, but it can help us to make a management decision. But of course, we also need to compare and share this with our patients themselves to make sure it's acceptable to our patients. And there's no one better to talk a little bit further about this, both in the context of treat to target, but also in the context of real-world data, than Professor Alton. And so it's going to be my great pleasure now to hand over to Professor Alton so she can tell us further about this. So Riki, over to you.
Peter Taylor, thank you very much for the kind introduction. And I'm hoping the slides are moving forward. My topic is treat to target and the treatment strategies and recommendations. So the slides are not moving. I hope they will do it soon. Let's try again. Otherwise, you should move the slides. And I say, next slide, please. Actually, it's not moving. So let's move forward. Callum, can you please move the slides forward? Can you hear me? Yes, thank you very much. So my topic are the treatment strategies and the recommendations overview. The treatment target is remission or a state of at least low disease activity, which should be attained within 6 months. So next slide, please. We know that we have to prescribe methotrexate as the first-line therapy at an optimal dose of 25 milligrams weekly, and also in combination with glucocorticoids in the beginning. So the overarching principles we are all aware of is that we really want to reach the long-term health-related quality of life, which is good for our patients through the symptom control, the prevention of structural change and damage, which we have seen more and more in the last years, but which becomes more and more important. And I was wondering why in one of Peter's slides, the HAG-DI was ranged in a very low position. The normalization of function, and this we see in our German database and also in the rabbit registry, is really very important from the very beginning on. And for the patients, of course, participation in private and work-related activities is very important. Next, please. Next slide, please. So what does it mean, really? Treatment to target contains measuring disease activity and adjusting therapy accordingly. And this is not always possible due to the not enough availability of rheumatologists, for instance, in Germany, which we will see later. Next slide, please. So clinical remission is the primary target. But when I look at my own patients, I can say that at least 40 to 45% of the patients are remaining in low disease activity. And for them, it is also an acceptable alternative, particularly if we have patients with a long-standing disease. What we do is really to measure, and this has been reimbursed in Germany for many years now, to use validated composite measures of disease activity and to do joint assessment, which is really needed in routine clinical practice to guide the treatment decision. Next, please. Can we have the next slide, please? I'm sorry that it's not moving by myself, so thank you very much. So how often do we measure and do we see our patients? Monthly is not feasible. Especially patients with high or moderate disease activity, we can see them only every 3 months or less frequently. So that is really a problem in our daily care. So the rheumatologist wants to involve the patients in setting the treatment target. And later during my talk, I will show you data from a recent survey, which we performed, and we see how the patient was involved. Next, please. Now I go over to some guidelines. We have the recently published American guidelines. They also have written teach target on their agenda, and also the modification of DMARDs, especially the addition of bio-DMARDs for those patients who are not already at a target. Next, please. So here, already the question of glucocorticoids is addressed. The addition of switching to DMARDs is conditionally recommended over continuation of glucocorticoids for patients taking glucocorticoids to remain at target. This is a very important point. And as we have heard at the recent EULAR conference at Copenhagen, in the new EULAR recommendation, glucocorticoids are also in the focus of interest. And I will show you Italian data later, where you can see that the glucocorticoids really matter. And also our German rabbit data have shown this already for years, that glucocorticoid dosages above 5 or 7.5 milligram really matter to the long-term outcome of the patients. Next, please. So the EULAR has defined the difficult to treat rheumatoid arthritis patients. And every day we see patients, and these patients pertain to fulfill the definition of difficult to treat patients with rheumatoid arthritis. And by the new EULAR recommendations for the management of rheumatoid arthritis, we now have clear recommendations what we shall do with these patients. And what is so important to detect these patients, the presence or absence of inflammation should be established to guide pharmacological and also non-pharmacological interventions. If we see a patient, especially in our daycare, as I saw some patients today, they have about 28 painful joints and no swollen joints, and have we had several DMARD treatments without any effect, then you really have to double check the diagnosis. Next slide, please. So if a patient has a presumed difficult to treat rheumatoid arthritis, now I go already to the relevant mimicking diseases in those difficult to treat patients. One important disease is polymyalgia rheumatica, but also the spondyloarthritis. But last but not least, and here mentioned as the last active diagnosis, is indeed fibromyalgia. If we have no inflammatory signs and we have really high pain level, we always have to understand whether these patients are possibly suffering from fibromyalgia. So they have to be treated totally different and with a different approach in a multidisciplinary team, as we do it together with our colleagues from the psychosomatic department. We also can help these patients, but they are not helped with targeted synthetic DMARDs or bio-DMARDs. That is very important. So I try to click and hopefully it works. No, next slide, please. So again, here are some points, and I mentioned it already. For these patients who are difficult to treat, a self-management program is important, and education and also psychological intervention is necessary to optimize the patient's ability to manage the disease confidently and really to learn self-efficacy. That is really important, and comorbidities have to be treated by the specialist and carefully managed and considered. Next, please. So the EULAR has in 2021 also given us recommendations for self-management. And here the overarching principles are mentioned for taking an active role in learning about the own condition and also in this shared decision process, because that is not always clear to the healthcare professionals and also not clear to the patients. So personal confidence to carry out an activity, patient has to learn with the aim of achieving a desired outcome. That has a positive effect on various aspects of living with inflammatory arthritis. Patient organizations are often very helpful to learn self-management programs, and in collaboration between HCPs and patient organization, that is a very great benefit for the patients. We have the German Rheuma Liga, which has really very good courses for the patients, but we also do offer these training courses for our patients in the daycare clinic. Next, please. Next slide, please. So again, patient education is mentioned. That should be the starting point, and really instruct the patients to learn problem solving and goal setting. And we also teach our patients in lifestyle changes. We have a lot of evidence on this, like smoking, cessation, and like movement and physical activity. And in some patients also mental health has to be improved, and it has to be assessed periodically, because many patients really need intervention also in this field from our colleagues from the psychosomatic or psychiatric department. Next, please. So we should be the person who is inviting the discussion with the patients about the work, and signpost always where we can help, or we have also social workers in our clinic, and they can really also help patients who want to go back to work, or in some situations also patients really who still want to go into, they are close to the age sometimes. And especially for this point, digital healthcare has become of more and more importance, and really patients can learn how to self-manage their situation and really to be included and interested in the self-management programs. So that is a new field, and I think this will be the future, that the patients are more and more active, especially also to learn about available resources. For us in our clinic, for instance, history of workplace situation is very a part of our assessment. And I think this is really important, because many patients need help also in counseling in this field. Next one. So these are the data of a recent study. Or can we go back one slide, please, for the treat to target approach of a recent study, which is under review now, where we, in real world, thank you very much, only 1/3 of patients with rheumatoid arthritis are involved in setting the treatment to target goals in clinical practice. And this is part of a survey which we did together with other colleagues, and which is under review now. And especially patients with really high and moderate disease activity are not really involved in setting the treat to target goals in clinical practice, what we saw in this study. Next, please. So the treat-to-target approach, as mentioned, is based around the principles of shared decision between the patient and the rheumatologist, and it improves the prognosis of patients with rheumatoid arthritis and forms part of the treatment recommendations of EULAR and also of the ACR. And there is great evidence that a treat-to-target management strategy yields superior medium and long-term outcomes, prevention of damage, maintenance of physical function, and also reduction of the burden of comorbidity compared with standard of care, both in early and late era. Next, please. So although treat-to-target has been widely endorsed as the strategy of choice for the management of rheumatoid arthritis, there is a high need to commit to treat-to-target strategies and individualized treatment decision-making. There are limited data so far on the degree of implementation in the real-world clinical setting. There are also indications that treat-to-target has not been extensively adopted, and therefore there are many opportunities to increase the application of treat-to-target in daily clinical practice. And on the next slide, we see the data of 5 European countries and UK. Next, please. So the objective of this present study was to explore the implementation of treat-to-target. And you can see here that the physicians, patients' concerns regarding infection was really 1/4 of the physicians who selected this response. And there are many reasons why the patient not currently receiving advanced therapy if their clinical condition wants it. We can't go through all the details here, but also a high concern for the patients are safety issues. And for me, this is a result of not sufficient communication between the healthcare professional and the patients. Next, please. Next slide, please. So most important treatment goal for the physicians are indeed overall safety problems. And the data you can see here on this slide, that the majority of physicians state that they follow treat-to-target principle in at least some of their patients with rheumatoid arthritis, but more than 10% said that they never use treat-to-target. And I have to say that the German healthcare professionals did not have the best results in this survey. Next, please. So you can see here in which patients with rheumatoid arthritis you would follow a treat-to-target management approach. And this is also the physician statement, both moderate and severe patients. That is really 3/4 of the patients, but they are most likely to implement treat-to-target in both moderate and severe patients, but not in all patients. Next, please. Can you please move forward? Thank you very much. So we move forward and we can see, I cannot see the slide very nice. Now it's good. Only 31% of the patients. Oh God, can you go back, please? Okay. What treatment? Yes, only 41% of the patients and physicians agree that a treatment goal was set. In 1 of 4 consultations, neither the patient nor the physician recognized a treatment target, and these results are not very encouraging. Let's move forward. Next one, please. As we can see, there is a high discordance, and also here, again, in the treatment goals we have set, there is a high number of discordance. And also when the question was offered to in the survey whether the treat-to-target goal has been achieved for the patient, also again, the German colleagues did not have the best results. The German physicians felt the most confident, but as we have seen in the results before, that is really not the result of the overall survey. So let's move forward, please. Then we can go on to other real-world data. To conclude this part, I can say that a high percentage of rheumatologists indicated that they used treat-to-target principles. But on the other hand, when rheumatologists and their patients were in agreement on treat-to-target, and the patient was aware that the treat-to-target goal had been set, this resulted in higher rate of satisfaction, higher patient engagement, and of course, in greater success in achieving the target. So it is really of great importance that patients are accepted as real partners in practicing treat-to-target. Next slide, please. So now we come to another part with the question, how well does real-world experience meet the expectation? And I brought you 3 examples from Europe, one from Sweden, and one from Italy, and one from Spain, concerning real-world experience with baricitinib, with Olumiant, and moderate to severe rheumatoid arthritis. Next slide, please. Can we? Yes. So the Swedish data showed us that kinase inhibitors are overall at least as effective as BioDMARDs, and that especially baricitinib may be more effective than TNFs. Baricitinib showed significantly higher retention rates compared with TOFA or TNFs, and was less often stopped due to reported ineffectiveness within the first year. Next slide, please. Here you can see the effectiveness of BARI and the retention, and also TOFA compared with BioDMARD and rheumatoid arthritis. Results from a cohort study using nationwide Swedish register data. And here the crude drug retention in the Kaplan-Meier curves. Next one. Next slide, please. So especially here, the data for the CDAI remission showed us that the data for BARI were very convincing, and also what I mentioned before, the HAQ-DI improvement was also shown very nicely for a better outcome for baricitinib in this Swedish register data. These were the differences between the proportion of CDAI remission and HAQ-DI improvement at year 1. Next one. So the Italian study population contained nearly 500 patients with rheumatoid arthritis treated with baricitinib in 11 Italian centers between June 2018 and November 2019. The patients were evaluated at baseline and after 3, 6, and 12 months. And the primary endpoint of this study was the assessment of disease activity changes after 3, 6, and 12 months with thus CRP and also CDAI. Next slide, please. So you can see here the patient population. Most patients were treated with 4 mg baricitinib daily, and there were a high proportion of BioDMARD naive patients, and also patients in methotrexate combination therapy, but also monotherapy. Next slide, please. And what is so important, and this is really a very short version of this trial results, is that it was possible during the study period to reduce or withdraw the oral glucocorticoids totally within the observed time when the newly initiated baricitinib treatment was started. This is very important, and it's already in line with the new EULAR recommendation. Maybe we can discuss this later. Next slide, please. So the Italian data support that BioDMARD naive patients showed a better clinical response as expected, and BioDMARD naive patients had also a significantly higher retention rate at 12 months, despite similar baseline characteristics and disease activity. In this study population, the younger age, a shorter disease duration, and lower rates of comorbidities was in the BioDMARD naive group observed. And so a higher proportion of these patients achieved remission at month 12, 50, respectively 25% of the BioDMAT population. Next, please. So 50% of the patients, as I mentioned already, can withdraw from the glucocorticoid. That is a very important result. So also the pain was reduced by JAK inhibitor treatment and independent of the effects on inflammation. And the study also reported a rapid effect, as we have seen already in the randomized clinical trials, on pain and also on fatigue. But this has mostly shown as early as month 3. Next, please. So the next group are the data from Spain, also a multi-center retrospective observational study of adult patients with rheumatoid arthritis. They started baricitinib between September 2017 and May 2019. And the ORBIT study, as it was called, was designed to investigate patients' profiles, treatment pattern, effectiveness, and also persistence in patients with rheumatoid arthritis. Next one. So here you can see the treatment pattern. Most of the patients really received baricitinib in 4 milligram dosage, as you can see here, the higher proportion of patients, but interestingly also a high group of patients in monotherapy, which is a very important option, especially for those patients who are intolerant or have side effects on methotrexate. Next one. Here you can see the data for persistence, and you can see that the data showed that baricitinib patients had a high persistence during the observational time in combination with CSD-MATs, but also in monotherapy, which is very important for our patients and a very important option. Next, please. So in Spain, patients with rheumatoid arthritis treated with baricitinib had a refractory and long-lasting disease. Most of them started their treatment in combination with CSD-MATs. Persistence with the treatment was high. It was higher in patients treated with combination therapy with CSD-MATs, with double positivity for rheumatoid factor and ACPA. That's also very important information, and also with fewer comorbidities, reaching maximum values in patients with previous BioDMAT failures. High remission and low disease activity were observed from month 6 to month 12, regardless of the activity index used, CDAI, DAS, or whatsoever. These findings suggest that BARI is an effective treatment in real-world clinical practice setting. And I think I'm now at the end, so I can overall conclude in all 3 examples from Europe, baricitinib has shown a very good efficacy, measured not only by disease activity, by DAS, CDAI, SDAI, but also in the function measured by the HAQ-DI. In all these 3 real-world populations from Northern and Southern Europe, a comparable persistence has been shown by high drug retention over time. The possibility of the reduction or withdrawal of glucocorticoids has been shown especially by the Italian cohort. And last but not least, for the next slide, please, I would like to share with you some data which we have recently seen at our German conference and also at the US. These are the data from the German register. Can we go back, please, to the slide? Investigating the question of the risk of cardiovascular events under Janus kinase inhibition in patients with rheumatoid arthritis. We have investigated patients who were treated between January 27 and April . Yeah, now I'm back again, I think. You can see here the flow of the patient selection, which were included in the rabbit study. And then especially the population was standardized, very similar to the oral surveillance with the risk factor, one cardiovascular risk factor, hypertension, coronary heart disease, diabetes, or proteinemia, and also current smoking. And the interesting result, you can see it on the next slide, is that the patient's characteristic at treatment start were elderly patients, mostly women. Here you can also see the function. As I mentioned before, function is very important, and the steroids were not so high, less than 20% normally. And the next slide, please. The crude incidence rates were 100 patient years, you can see here. And the next slide shows the result. Yes, we can see here in comparison the data of the rabbit investigation and the oral surveillance, and also the star error. And what we found, despite the fact that we had the same risk factors like in the oral surveillance, that our patients did not have the same negative outcomes like in the oral surveillance. And our interpretation from the rabbit here is that might be the physicians already made a very professional patient selection for those patients in which they started treatment with small molecules. These data are not fully published so far. They are only presented orally, but I think they really are very important as real world data. And I excuse myself that the slides did not move so forward as we planned, but nevertheless, I hope you got an interesting insight in the newest data also of the real world, which we collected together. Thank you very much for your attention.
Vicky, thank you very much indeed for a wonderful talk. So we've learned about the importance of implementing treat to target, but also how real world data can help corroborate clinical trial data and indeed shed new light on controversies, as you've just illustrated with this very interesting German data. So we have time just for a couple of quick questions, and we've had a couple regarding JAK inhibition from our audience. The first is, can we switch to an anti-TNF after failure of response to tofacitinib? And
actually, I know only one study switch from after small molecules to IL-6. There is one study I learned about, but I have no study in mind switching after small molecules to anti-TNFs. I don't know. Do you have some data?
Not any data, but there certainly is some experience, because some patients might prefer initially to have an oral advanced therapy, and there will be some who don't have an adequate response, and then to move on to a parenteral treatment such as anti-TNF is a perfectly reasonable thing to do unless there are contraindications. So I think that is absolutely a legitimate way of doing things. But as Vicky says, that there's no trial data that I'm aware of. And then the other question is also about JAK inhibitors, and it congratulates you on a very nice talk, and says that can we use baricitinib in seronegative rheumatoid patients? And that's a nice, easy answer to that.
Actually, I'm just preparing a talk on this question. And so far, of course, we can use it, definitely. And I think the data are interesting, which I presented concerning ACPA and rheumatoid factor, but that does not say that small molecules, especially baricitinib, is exclusively only for patients who are seropositive or double seropositive. That would be a one-way street. I use it also, and I have used it, of course, definitely in seronegative patients with good results.
Absolutely, and the same is true for me. We mustn't forget, of course, that the clinical trials are often biased towards more seropositivity because there are selections of poor prognostic factors in order to power for radiographic progression analysis. And last question, perhaps if I may take, but you might want to comment on briefly, Riki, is in the safety issues in clinical trials, is it correct to interpret data when the sample size was not calculated for that objective? And I'd like to thank the viewer for raising this question, because it's a very pertinent one. It's extremely difficult to reliably interpret these type of data, and oral surveillance is a very good example in point, where there's a relative risk difference that doesn't meet statistical significance, and there is no known at the moment pathobiological mechanism to account for the apparent association of the adverse event with that particular drug. So really there are a lot of unanswered questions, and I think where there is uncertainty, we must apply our clinical acumen in very much the same way it would appear our German colleagues are doing, and is reflected in the data that we've just seen. But all of these issues need to be interpreted with some caution. And perhaps, if I may, I would suggest that we need to be very careful how we communicate them to the patients, because on the one hand, we need to be open about benefit and risk, but on the other hand, if we overly emphasize risks that are not real, the patients are unlikely to derive the benefit from the drug because they probably won't take them appropriately. So this is a difficult path for us to follow. So we use the evidence base as it's available, and we keep on following the evolving evidence base. That's our responsibility as clinicians, to make sure that we appropriately inform our patients, but emphasizing the best achievable outcomes, I think. But would you agree with that, Riki?
Actually, I think it's still too early to draw really clear conclusions, for instance, out of the oral surveillance study. For me, it's not possible, and I'm still waiting for other data. And there are so many pitfalls in interpreting these data that they do not show in one clear direction for me. And it's very good that we did this analysis in Rabbit, and hopefully other registers will follow, because then we get more information and really can evaluate the results we have so far, because we need data, and especially concerning safety. We are the person who our patients trust, and they need our understanding, but our careful interpretation of the data so far we have so far.
Thank you very much. Yes, I absolutely agree. Well, I think we now need to draw our live forum to a close. So I'd like to thank all our viewers, and to thank you very much, Professor Alton, and wish you all well. Look forward to the next